So moving on to future directions and current management. So do you give children food and diarrhea or not? So diet modifications and acute diarrhea are common across cultures. So it doesn't matter whether you're in Cameroon or you're in India or you're Pakistan, the US. People think if you don't give food, you'll have breast diarrhea, which is 100% correct. You don't give food, there's nothing in your system to make more stool. But is that good for you? So I'll show you some data about whether it's good for you or not and what we recommend. So food withholding is very prevalent. Most commonly, people talk about this brat diet. It's a banana, rice, apples, toast. And then overall, just when a kid's not feeling so well, these like dehydration or acidosis, that in itself may limit oral intake. So why did this resting the gut gain prominence? So there was a lack of understanding of the infectious pathophysiology. So you and I know that the reason why you have more diarrhea when you eat food is because there's more there's more matter for the infection and your gut and all to act upon. If you starve someone, so if I stop eating, I will definitely have less stool. Sick children have anorexia. And then there was this concern that, oh, if you give food, it'll exacerbate nutrient malabsorption. But is that true or not? So this is a slide. It's actually pretty old, and that's why it's so interesting that food withholding still persists. So this is from 1988 by Ken Brown's group, and it looks at 4 different groups. And so I want you to focus on group 1 and 2. CSO stands for casein, sucrose, dextrin, to provide a total of 110 kcals per kilo. And group 2 is the same thing, but half the calories, so 55. And then I want you to focus on both of them. The y-axis is fecal weight. So yes, if you give people food, which is what casein, sucrose, dextrin is, they will have more diarrhea. But does it persist? So in roughly about 2 weeks, the amount of diarrhea is unchanged whether you gave them more food early on or less later on. And importantly, just as to know what the comparison groups are, group 3 is like oral glucose solution, and group 4 is IV. So if you give IV in an immediate child who's having dehydration, presenting with diarrhea, you'll have the least amount of immediate diarrhea you see, but is it good in the long term? And what the study also did is it looked at absorption of nitrogen, fats, carbohydrate, and total energy. And what the groups with the CSO diet, so the carbohydrate dextrin diet, with continued oral feeding, improved overall nutritional results. And this is looking at cumulative weight change on the same diets, and you'll see the same top 2 diets, group 1, group 2, looking at whether it was 110 or 55, giving some nutrition overall, even in that context of diarrhea and villus blunting happening, your body still does absorb nutrients. So bottom line, you should give food. But again, just to drive home the point, this is a survey 10 years later from that study. This is 1998 in the US, and it looked at MD practices of feeding during diarrhea. And about 1/3 of physicians still stop feeding during acute diarrhea. I'm pleased to say that most people recommend continued breastfeeding. But again, there was all these other things that we don't necessarily advise, such as diluting formula or giving the brat diet. And then just again to show what does the brat diet have compared to a represented toddler diet. So the brat diet barely has anything. So DRI talks about your a goal dietary nutrition intake. And so your representative toddler diet is way above the DRI for vitamin A, B12, and calcium, and the brat diet barely has anything. So in summary, from what NASPGHAN, which is our Pediatric GI Hepatology Nutrition Society, we recommend early refeeding. We know that even if there's injury and there's villus atrophy and there's bad infection going on, growth luminal content, so having anything in your gut lumen is a known growth factor and helps facilitate mucosal repair. So that those beautiful villi that I had shown, one of their main sources of nutrition is not just what you what's in the blood, but also what you take in your mouth in terms of bathing those villi in nutrition. So what about dairy-free? So I explained to the families that the tips of the villi have an enzyme called lactase, and that helps break down lactose. So you can have transient lactose intolerance, but just to highlight that it's the lactose, it's not the protein, it's not dairy protein. So it's okay to give lactose-free formula until mucosal recovery is complete, around 2 weeks, but this is very variable because it all depends on how much mucosal injury there is. And then older children can continue eating a regular diet, and the brat diet is not recommended. So what about ORS? Appropriately formulated ORS is a therapy of choice, and by appropriately, you know, at least in my practice, there's so much confusion as to how to mix the ORS right. Is it Pedialyte? Is it Gatorade? Should we mix the Gatorade with some Diet Coke? Bottom line, don't mess with the ORS. Buy it the way it's indicated, make it the way it's indicated, and then just take that. It doesn't taste so great, but that's the optimal concentration of the sugar and the sodium molecules to help absorb water. And then zinc supplementation, so likely good idea in areas where dietary zinc deficiency is poor, of low bioavailability. And then in Western countries, it's sort of unclear. I'm going to talk a little bit more about zinc because I think Cameroon is an area of a relative insufficiency. So zinc is a micronutrient deficiency, which is noted in malnourished children with diarrhea. The WHO does recommend supplementation in the context of acute diarrhea, both with different doses for children age greater than 6 and then older kids, usually for 10 to 14 days. The benefits have been to reduce severity and course. That recommendation is based off this study. It was published in JPGN in 2004, and it basically shows that the overall stool output and duration in hospitalized children decreases if you give zinc. And I'm going to show this other slide, which showed basically very little effect in very young children. So these are not significantly different. And this is just to say that if you're suggesting zinc as per recommended WHO, and a very well-educated family comes up to you and said, well, you know, some of the data is unsure, and you can say, well, that's true. There is this study from 2006 in which the effect size between zinc and placebo was essentially the same, but currently the WHO recommends zinc in areas where there's zinc deficiency, and that should be a rationale for giving it. So what about other treatment options? So antibiotics, immunoglobulin, or probiotics. So remember the GEMS data that we've shown, what you're trying to weigh is this rotavirus or not? And then just even if it's a bacterial infection, it may prolong illness, carrier state, and morbidity. The situations in which antibiotics are always indicated are Vibrio cholera, Shigella, Giardia. So usually either a third or a third generation cephalosporin, and then Flagyl, so metronidazole. And then antibiotic therapy in select circumstances would be for enteropathogenic E. coli, enteroinvasive E. coli, Yersinia, and Salmonella in the context of either long duration, sickle cell disease, or Salmonella in a very young child. And then just remember those 4 pathogens. It doesn't say rotavirus here, but those 4 are rotavirus, Crypto, Shigella, and toxigenic E. coli from the GEMS data. And then, so what about immunoglobulin? So immunoglobulin is essentially the pooled antibody in the blood of like 1,200 volunteers, right? So it has not just IgG, it has IgM also. It probably has some element of IgE. But what they found is in trials of rotavirus diarrhea, if you give that immunoglobulin enterally, it just sort of sweeps up all the antigen and it reduces diarrhea, but it's very expensive. So we suggest, NASPGHAN guidelines say you can give it in the treatment of patients who are immunocompromised or such as HIV. And then current evidence does not support its use in rotavirus in LBW infants. And then what about probiotics? So the biggest thing about probiotics is that it's very variable. So what the box says about the composition and the type of bacteria that is when they made it, right? When they packaged it. And then it goes from the packaging, it sits on the shelf, and then you buy it and it stays in your home, and then you take it and mix it and eat it, right? So the composition is very variable. The thought is that when it does work, it helps by modifying the composition of your colonic flora, but the mechanism of action is unclear for the reasons that I mentioned before. It may be effective against acute diarrhea, and it's mostly lactobacillus or Saccharomyces boulardii that's been shown that works. And then for acute diarrhea in developed countries, such as the US, it's been shown to reduce duration of diarrhea by about 1 day. And so mostly it's been evident in the context of viral diarrheas. And then lastly, talking about prevention, so education, sanitation, hygiene, so simple hand washing, breastfeeding, food safety, because as we saw, the pathogens that lead to diarrhea are transmitted by the fecal-oral route. So it's important to talk about correct and appropriate formulation of food, use of ORS, probiotics, and then development of oral vaccines such as rotavirus, but then also for Shigella and cholera. So going back to the case, so that 8-year-old who was having lots of diarrhea, was from a high endemic region. So now thinking through the clues in this case are the daily loose stools, the fact that there's linear growth faltering. So this child had a stool ONP and culture that shows cryptosporidiosis and was treated with nitazoxide or Alinea and improved. This case, so this was very interesting. The reason why I put it here was just to think that even though you want to be thinking of infectious causes as the primary cause of diarrhea, if it persists, you want to think of other differentials. So this patient actually had celiac disease and was significantly malnourished as a baseline because she had not known about her diagnosis and not known that she needed to be on a gluten-free diet. She actually eventually developed tuberculosis and then developed liver failure from anti-TB treatment. But now is post a liver transplant, is doing great. But just kind of thinking through the list of differentials.